Hello, hello everyone. uh, this time I'm here with another uh, video. On this time I'll be talking about disease of uh, or disorders of a short resume of psychiatric diseases in old people. You can say it's a small review or something, because it's not possible to do one talk of psychiatry in 30 minutes. So I'll do about two videos actually, one in English, one in Malayalam. The English one is this one. So here goes. First of all, I'll say the general impression of everyone that psychiatric illness per se decreases as one becomes older. For example, an 85-year-old man may not have the kind of disease which psychiatric illness which below 60% has. For example, he may not have this anxiety disorders, all those things. Even mood disorders can come down. By the way, when I say mood disorder, I hope everybody understands. Mood means the mode you are in. In Malayalam we say that particular that emotional that content of that moment, that's mood. So mood disorders are there are two disorders only. One is the anxiety. That's what you feel generally. Anxiety and spectrum. You can say I would like to say spectrum. For example, what is a spectrum like that? Anxiety spectrum disorders. That includes your generalized anxiety, then social anxiety, and anxiety even separation, what's called separation anxiety, or you're anxious that somebody is going to leave you, separation anxiety, and all the kinds of phobias, they're all anxiety. So anxiety disorders are not there in old age. I'm not saying not there, it is there, but it is less than 50% of people who are younger. Also, the other part of mood disorder, which is anxiety, anxiety means it produces a lot of positive symptoms. In having read this thing, the psychiatric part of it, I am tempted to say that positive symptoms are there. Positive and negative symptoms are usually seen in schizophrenia. You can say that in anxiety also. Anxiety is kind of positive symptoms only. And depression is mostly negative. But depression is a spectrum, another spectrum. It's called bipolar spectrum. People who have depression can go to the extreme extent, the other extent, the polar extent. It's called bipolar. Bipolar. From one pole to the other. You'll be depressed, very negative, goes to the extraordinarily positive or extremely positive. That's called mania. Mania is another name for a madman, like that. So they become mad to sad. Sad to mad, mad to sad. That's a bipolar disorder. So these are the mood disorder. These are the incidence is low in old age. Schizophrenia incidence comes down. But when schizophrenics become old, they are known as burned out or they are called graduates. They graduated. After 60, 65, they graduate. But the symptoms go away. Actually, they don't need a treatment at that stage of life, schizophrenia. That is after when they become senile, become old, they don't need any treatment for antipsychotic medication. Most of them lose their positive symptoms like hallucinations, delusions, and all those things. Illusions. Everybody knows what is a hallucination, isn't it? Hallucination, you are hallucinating, you are seeing, your senses are deceiving you. You are seeing something, you are hearing something. That is hallucination. Delusion means there is a belief that I am the prime minister today. Delusions. And illusion means you again your senses are playing with you. Like the illusion of something, illusion, you see. uh, it's a false belief. Illusory, it's called illusion. Uh, what can I say, which is more delusion and illusion are related, but the delusion is more on the other spectrum, the mad spectrum, delusion. Whereas illusion, you have some kind of this thing is there. You have a self-knowledge is there that this may not be correct. So that is illusion. Whereas the delusion, the person may not be aware that he is having this thing, sensory symptoms, because he is sick. So that is the main difference, illusion, delusion. Hallucination means you always hear something, you see something, sensory, deceiving you. That's actually perceiving, hearing sounds, hearing as if somebody is speaking to you, somebody is commanding you even. They make you passive, as if some commander is there, and he is asking you to behave as if there is he is broadcasting something. He's telling you do this. Okay, these are the things. The mood disorders, psychotic disorders, both are less in old age. Lesser by 50. We can generally, statistics may not be correct, but it's supposed to be. I've seen gone through many statistics, and it's around 50% less than in younger people. And this one, many of these mood disorders and psychotic disorders burn out, and or they graduate, and they lose the need for antipsychotic or antidepressant medication. Okay, so why is that? Why all people have this thing? Why don't they have anxiety and depression? Because there is some kind of learning is there as you grow older. Some kind the mood stabilization comes about because of your thing. Because of learning, as well as you become resistant. See, you have an adversity. There are two ways. You can become resistant to future adversity, and you can another effect is you can bear the sequelae of the adversity. That is called post-traumatic stress disorder. Post-traumatic, that is that. So even PTSD, post-traumatic stress disorder, is less in older people. So what is more in older people? The usual things. What is more? Dementia is more. Then the structural brain lesions are more. But the corollary is the structural brain lesions itself can produce depression. That's why some statistics might show that old people have more of depression, because those who have stroke, there is a statistic, 30% have depression. Like that, those who have Parkinson's disease, they have more depression, like 70%. So, but it's very difficult to say whether there is depression or the thing. Parkinson's disease. Parkinson's disease itself has got some kind of psychomotor retardation. So, but that is a statistic. About 70% Parkinson's have this thing. Another thing is, old people, when they have a lot of medications, out of those medications, for example, beta blockers, certain endocrine things like estrogen, tamoxifen, all those things can make you depressed. That is the reason why some old people develop de novo depression. Generally, depression has a history in the younger age, but those who become depressed in old age also. But those who become de novo, maybe one of the research will be this one anti-Parkinsonian drugs, beta blockers, tamoxifen, all those things. And also, those who have disease like very, very severe disease like cerebrovascular disease, malignancy, there needs no no further explanation. You are bound to have some amount of anxiety, some amount of depression. Anxiety will come first, then they'll become depressed, and they'll get used to it. That's how it is. Then there is a statistic about post-traumatic stress disorder also in old age, around 3% in war veterans. 3%. But actually, the generalized anxiety disorder, everybody knows what is anxiety, isn't it? You have fear of, it's called foreboding, always thinking something going to happen. You get, they get body symptoms because of that, some palpitation. Sometimes you'll get some headache, this thing, that thing. Of course, if you get those physical symptoms only because of this mental problem, that's called somatization. That is, you are making the mind the body, or it is a mental disorder manifesting as physical disease. That's called somatization. Somatization, actually, it's also again a spectrum. Somatoform disorder. Somatoform disorder means somatization is bodily this thing. Another form of somatoform is called what's called conversion. In conversion, they have always neurological symptoms. If somebody has neurological symptoms without any basis, and you think it's psychologically induced, then it's called a conversion. It used to be called hysterical conversion. No, I think now it's just called conversions, this thing. So all these are somatoform disorders. There's another thing, it's called dissociation. Dissociation means you dissociate from your personality, the whole thing. Your thinking, your identity. Sometimes even your identity. You tend to lose your identity. It's called, this disassociation. Just what it means. You are associating or disassociating from yourself. You take up another personality. Dissociation. That is not seen in old people at all. It is dissociation. Dissociation is not seen in old people. So if somebody is having a dissociation in old age, that means he has a brain disorder, dementia or whatever, or as a tumor or something, dissociation. So this is what is in the introduction I can say, but the corollary of depression and anything is depression in a young age as well as in old age is the suicide risk. People having a lot of depression. Depression means sadness. Depression is sadness equal to sadness. So a lot of sadness, when you can't bear it, unbearable sadness, what can you do? Then you can't do anything. You can't go out. You can't, your relationships have broken down. You have no way to exist. You try to. If there is no way to exist, you exit. So that's suicide. You try to kill yourself. That sui means swaya in Sanskrit. Suicide. You kill yourself. Latin. So the risk of suicide is there in all depressive. But when I'm talking about suicide's risk is quite high in old age, because generally they will complete the suicide. Old people complete the suicide. Young people attempt suicide, but old people generally complete the suicide. When they decide to die, they die. Hmm? One thing, because life becomes unbearable. They will have physical illness, like somebody having malignancy, somebody having, you know, unremediable pain, some pain which cannot be remitted by any medicine. Uh, or somebody having simply what's called bereavement. Bereavement means it's a rupture of a relationship. Not because the relative is there, the relative died. And the closest relative generally people relate to is your spouse, or a wife, or husband, or whatever. So bereavement, but it not be that bereavement can be in any other way. If your favorite dog dies, there is an element of bereavement there. So that that is the suicides risks are more in old people because they complete the suicide and they have more chance of getting that kind of depression. I'll be touching on psychotic depression a little later because there are two kinds of depression. One is this mood disorder depression, other one is the psychotic depression. As I already told you, somatoform disorders actually has an increase in old age, some amount of increase in old age. Except conversion disorder. There is somatization. Old people generally somatize. And it is a symptom of depression in old age. If somebody somatizes, and most of them have, it's a depression, it's a symptom of psychotic depression in old age. If they will somatize gastrointestinal symptoms, generally, gastrointestinal, the constipation, this thing, that thing, bloating, or pain, abdominal pain, all those things. Watch out for psychotic depression. Why psychotic depression more important is, again, suicide risk is more in psychotic depression. But how do you differentiate? Generally, everybody should know. How do you differentiate the psychotic depression from other mood disorder depression? In psychotic depression, always the hallmark or the signs of psychosis means something very abnormal, you know. Psychotic. Psychotic means he is mad. So the symptoms are what's called hallucinations. Hallucinations or delusions. Delusion is mostly in schizophrenia. It's called paranoid. That is somebody is trying to harm you, or that is a paranoid feeling. Paranoid, or they will hear something. That's called. So in this psychotic depression, they will have some psychotic features also, like hallucinations possible. Another thing is, antidepressants are not enough to treat psychotic depression in old age. You need an antipsychotic itself. Generally, they give a combination of what's called, when I say refer to they, what I mean is the psychiatrist. I'm not a psychiatrist, but those who generally treat all these people, they give a combination of sertraline and olanzapine. Of course, olanzapine should be avoided if possible because it is a small risk of invoking or producing diabetes in the patient. In old age, especially in old age, those have a lot of comorbidities. There's a small risk is there. So, olanzapine and sertraline. Sertraline is an SSRI. SSRI means serotonin reuptake inhibitor. Well, of course, this somatoform also includes the pain disorder, you know. You can have pain. That's actually somatoform disorder has two parts. One is the factitious part, that is actually disease, the person himself knows that it is not there. Like he's sometimes called malingering, you know, he's just making up, or he knows he is making up. Other thing is he doesn't know he is making up. That is somatization, conversion, all those things. Huh? That includes pain disorders also. And also hypochondriasis, that's another entity called hypochondria. Hypochondria, I think everybody knows. Huh? Hypochondriasis. Hypochondriasis, actually, they don't want the treatment, they want investigations. Investigation. Most of these people, somatizers, they want more of investigation than treatment. Then so we were saying that the psychotic, all these disorders are 50% less in old people, but definitely there is a new onset psychosis also in old age. That is after 60, 65 years. New onset. They never had a previous episode of psychosis. In young but it's quite different from a young psychosis in the sense that they will not have any positive family history. They may not have. Or adverse life events which can predispose to this thing. But it happens suddenly after 60 years. And most of these people can have a sensory deficit, especially not sight, but hearing. Hearing is very important. If you can't hear, you can make up anything. You can have auditory hallucinations, something like that. So they can have hallucinations because the old age new onset schizophrenia. That will be about maybe about 3% of the schizophrenia. If you take the whole thing, young, old, the old age new onset may be about 3%. Anyway, less than 10%. And the another thing is, this schizophrenia may be associated with brain lesions. So always rule out brain lesions. It may have strokes, tumors, things like that. And regarding treatment part, you have to be very, very cautious in giving antipsychotic medicines too. Usually, antipsychotic medicines produce a lot of adverse side effects, especially the Parkinson type side effects. So, give the smallest dose required, and usually give the recent type of antipsychotic. The what can I say? The second generation, or it's atypical. It's called atypical antipsychotic medications. But try to avoid risperidone. Risperidone is, I think, the first atypical antipsychotic. It has a cardiac effect. I don't know what's the incidence, but it could be very low. But what they say is, risperidone, even if you give a small dose, it can produce ventricular tachycardia. the beat of rhythm change in the heart. So it's not dose related. So anyway, avoid risperidone in old age psychotics. I'm specifically talking to doctors about this. There is another type of psychosis in old age, the usual thing, the paranoid. And the difference between paranoid psychosis and the real psychosis is that in paranoid psychosis, they just have paranoia. Paranoia means delusion. That somebody is going to, especially females will think, they will want to say that they are being sexually exploited by somebody. So, hallucinations are not there in this paranoid thing. Whereas in the late onset schizophrenia, hallucinations, auditory hallucinations are there. And but both these things, the difference from young schizophrenic is that they don't have thought disorder. I'm sure everybody knows about a thought disorder in schizophrenia. The schizophrenia will start. You talk to a schizophrenic person, then he will understand. He will say something, then he will just shift from there. He goes from It's called a thing, like a move in a the chess play or something. They'll be moving like that. The thought disorder. Thought disorder is there, but that is not seen in old people. They have this kind of schizophrenia with hallucinations, and mainly paranoid. We can say the old age schizophrenia is one paranoid plus hallucination. Another is hallucination, paranoia without hallucination. So this is old age, and the treatment you have to be very careful. Treat with the barest or the smallest dose of thing, antipsychotic medication, and antipsychotic medications. I have alluded to the thing, this main thing. The atypical type. But if you don't want to give antipsychotic can be sometimes more dangerous than giving a small dose of ECT. ECT is, it used to be very common when we were all students, electroconvulsive therapy. Electroconvulsive therapy, even though started in the 1930s, it has got a lot of changes. Nowadays, it's quite safe to give ECT, especially unilateral ECT. So that could be the choice treatment for all these things in old people. for psychotic schizophrenia and psychotic depression. The difference in psychotic depression in old people from a young age depression is that they have higher rate of feeling of guilt. Negative symptoms are more, like feeling of guilt, psychomotor retardation. Negative symptoms are more in depression. Then, as I said, they can have auditory hallucinations. Then all the new onset or the psychotic depression, the new onset psychotic depression old age, they may not have history of all these panic disorders, anxiety disorders in many years, as is common in young age depression. Depression generally follows anxiety, panic, like that. Depression. So then if we investigate with imaging, these have this new onset schizophrenic appearance of the brain scan and the depressive appearance is basically quite different. In schizophrenic appearance, the ventricles are dilated. Whereas for depressive CT scan, the ventricles are not dilated, but there is an atrophy of the cortical cortex, especially temporal lobe, frontal lobe. That is the thing, imaging feature, and that you may not see in young people. So that means the old age psychosis has a structural basis also, probably. And there is the mania thing. I said bipolar in young age, mania. Mania can also happen in old people, but mania is not that common in old people. Mania means the hyperactivity, I said two spectrum for same bipolar disease. The lowest, highest. Lowest depression, highest is the mania, the overreactivity, the energy, the 70 years becomes 40 years with a lot of sexual exploits and things like that. That kind of thing. Mania, it can also happen in a young way, but quite rare. If you see that, always rule out a structural brain lesion in old people. Always rule out a structural brain lesion. Of course, treatment for mania also is it is not antidepressant medication, but it is a neuroleptic Usually in mood disorders with bipolar disorder, we give treatment, some anti-epileptic drugs like carbamazepine. It's called mood stabilizers. Mood stabilizers like carbamazepine, sodium valproate, and there are some typical antipsychotics also can be given. So that's about a short take on this thing, psychosis, mood disorders. Then there is another thing, and psychiatry is called personality disorders. A very fraught area. Personality. Who doesn't have personality? Everybody has a personality. Anybody who has a personality should have a disorder. There is no orderly personality. Then that means you are one of the masses. Everybody should have border. But what they're generally saying is some have got odd behavior. Everybody has odd behavior occasionally, but they have this persistent or the continuation of this odd behavior. That's why classified as the same. This one psychotic terminology is slightly modified. For example, schizophrenia becomes schizoid or schizotypal. There are two, schizoid and schizotypal. There are different. In schizoid, the person he doesn't have a communication. I mean, he doesn't have interpersonal relationships. Whereas in schizotypal, is a very odd behavior. He dresses in. He goes against all norms of society. Schizotypal. That's a this thing. Then there are the other, there's another thing called borderline personality. Borderline personality disorder means I think most people will suffer from it. Very common personality disorder. 50% of personality disorder is borderline personality disorder. I think I belong to that category. You have emotional ability. Then sometimes the relationship problems. And a constant sense of emptiness. You want to fill your thing with something. You should always have something stimulating you. Otherwise, you feel empty. So you should have something else. If you don't have, that's why alcohol. But the difference between borderline personality disorder and this one antisocial is very close actually. Both are antisocial, but in antisocial they harm others, whereas in borderline they harm themselves. Suicides are more common in borderline personality. Antisocial will commit a murder. That's the main difference. Both feel very empty. But that emptiness used to be lauded as what is called this one, when in my young age, it used to be called existential angst. But actually, everybody has some kind of emptiness. We don't know why we come to existence. So it's something to do with existentialism also. But it's the happy note is that when you become old, the antisocial personality, the sociopathy decreases a lot, becomes more sociable. And borderline personality just goes more and more into his cocoon. It becomes more and more of a hermit crab with a personality disorder. But another bright note is the suicidality, the proneness to commit suicide. Borderline personality disorder, everybody will have a history of attempt suicide, including me. Everybody will have. But that kind of thing, I won't consider suicide at my age now, 70 years. Okay, so that is a thing. Then this about finishes this our run through the psychiatric part of old age, and what can I do about personality disorder? there is a thing, something called I yesterday saw in the saying YouTube. That's something called dialectical cognitive therapy. Unfortunately, I couldn't go through it. What it means, but cognitive analytic therapy, all those things, all the rigmarole, then finally we will come to the one problem in old age, which may not be that much old in problem in India probably. This alcohol disorders, because are we an alcohol consuming society like the West? Kerala maybe. But alcohol is the problem with alcohol in old age is this again they had developed this cognitive impairment. Cognitive impairment means it's a broad spectrum. They lose all kinds of faculty. Cognitive impairment, memory. If you lose your memory, it's the alcohol could be a common cause. The most common are dementia, of course, the memory loss, stroke, traumatic brain injury. But the fourth commonest cause in the West at least, is alcohol. Because the statistics from the textbook of geriatry, that's why. Then another thing is, all these alcoholic old people, they may not be consuming food appropriately. So always give them thiamine, lot of thiamine, that gives some protection from brain injury. In alcoholics, they develop alcoholic withdrawal. Then another thing is they develop what's called Korsakoff psychosis, a kind of psychosis, alcohol. So always thiamine, if possible, give vitamin thiamine. Thank you very much. I hope it's only 30 minutes.